My greetings to you, fellow friends of MEMI from the US of A. Dr. Maria Geerhaugen here. I'm a clinical psychologist. I've specialized in trauma in both research and clinical work for over the past 25 years. Most recently, I worked at the Veterans Administration, the VA. I work with veterans, both men and women, in a residential setting. These are people who have disabling PTSD, for whom outpatient services weren't really viable. Their symptoms had become so overwhelming that day-to-day functioning was impaired. Maybe they've lost their job, relationships, often their home as a result. They've not only experienced military trauma, combat trauma, sexual trauma, other horrific scenes, instances of behavior in violation of their own morals and ethics, but often they've had childhood trauma as well, of all sorts. And so I worked with multifaceted PTSD across a broad range of types, durations, and complexities. Our theme for this year's conference is Beyond Trauma. But to help us understand this, I'm going to go deep into trauma itself. When we target things like anxiety, depression, phobias, addictions, or other challenges as our problem states, I found that many of these have their root in trauma. And in order to really understand trauma, we need to know about the brain. Trauma therapies need to take into consideration the way that people react to and experience the after effects of trauma, as well as incorporate what we know about the brain into treatment. I've come to trauma from a psychological background in trauma therapy. I actually started doing this work before we had any real therapies for trauma. When I first started at the VA, we had only our listening skills and an earnest desire to help people who had lived through horrific events. How things have changed. And they continue to evolve. We learn more about the human spirit and the brain and the ways that it's affected by living through trauma and adversity. At the VA, most recently, we employed traditional trauma treatments like cognitive processing therapy, CPT, and exposure therapies like PE, prolonged exposure, and written exposure therapy. Today, the VA calls these the gold standard in trauma treatment. Over time, I became frustrated that for a number of people, these therapies just weren't providing the help they needed. I became increasingly aware of the limitations of these approaches, and I sought alternatives that were more tolerable for my clients, less costly, and more likely to be successfully completed without sacrificing efficacy. I want to talk a little bit specifically about these limitations. First, they're too long. They usually require a minimum of 12 to 15 sessions, which is a costly commitment of time and money. Not many people can commit to several months of care away from their home, away from their family, away from other commitments. Number two, the scope is limited. During one of our admissions, which was several months in length, we could focus on just one trauma. And then we send them home for a minimum of 6 months, 12 months, before they can come back and work on another trauma. Commonly, these people had many traumas to work through. Number three, they're terrifying. Only people really with few alternatives are willing to seek care that has the reputation of being frightening and emotionally difficult. CPT and PE require detailing the traumatic event either in writing or verbally, and the repetition, either reading or speaking of the event again and again. This makes it very difficult emotionally and contributes to a high dropout rate, especially for PE. Emotional dysregulation is a symptom of PTSD. Not everyone who undergoes these treatments is yet able to manage their emotions or thoughts sufficiently to fully engage, participate in, and complete these treatments. Number 4, these therapies miss the visceral reality that those with PTSD live with. Oftentimes, by failing to address the visceral elements of the memory and focusing on the part of the memory instead that is cognitive, verbally available. As a result, there's a shallow impact. Not all people are aware of their thoughts, which makes CPT in particularly very difficult or really not a great fit for them. I've seen highly intelligent people who rationalize. They can use their brain to dance around thoughts and avoiding their emotions, which really reduces the benefits to them of these therapies. Beyond my experiences in the residential setting, we know that most people don't seek specialized trauma treatment. They often seek help first for anxiety, depression, relationship difficulties, trouble at work. Generalist mental health providers often don't have the background or training to provide specialized trauma care to their clients. This means that fewer people have opportunities to heal from traumatic experiences in their lives. We also know that secondary traumatization and burnout are challenges that providers of trauma care experience, making this work particularly difficult on a long-term basis. At my PTSD clinic, after just a few years, I became the senior provider. It was well known at the VA that PTSD residential care is a high burnout role. In my own practice, I use techniques like not visualizing what is being stated or written about, and being intently mindful in sessions to help lessen the effects of hearing other people's horrific experiences again and again and again. I also have quarterly practices to help rid me of the burden of these memories. I do these to stay fresh in my practice and to not allow the cumulative burden of this work to become unbearable. I hope you have similar practices. Lastly, these therapies don't incorporate the knowledge we have learned in the past 20, 25 years or so about the brain and its effect on trauma. All of that brought me to MEMI. Very glad to be here. I'm going to focus today on what we know about the brain and how it is affected by trauma and how these map to specific symptoms of PTSD. And then I'm going to talk about how MEMI uses this knowledge in unique ways in which, in my mind, addresses and obviates these limitations. Trauma therapy doesn't have to take so long and be so darn difficult. We know that brain structures and communication between key brain regions change as a result of trauma. When an individual experiences trauma, the brain shifts into a sort of permanent survival mode, which prioritizes immediate threat over rational thinking, being present, being aware, and long-term cognitive and memory processing. Dr. Bessel van der Kolk, who you may have heard of, is a preeminent expert in trauma who wrote The Body Keeps the Score, which you may be familiar with. He says fundamentally every part of the brain, more or less, is affected by trauma. The right brain lights up more. The left brain is shut down more. The back of the brain is more hyperactive. The front of the brain becomes less active. Research shows that developmental trauma early in life, blocks the growth of an integrated brain. In terms of functioning, this translates into seeing a person who lacks emotional balance. Maybe they can't clearly work under stress. They have difficulty with mutually rewarding relationships. They can't sit quietly by themselves. If you offer to do a body scan with them, they may have a panic attack when they're focused on their body. We've all seen such people. If you think of therapy, which I do, as a way of changing the brain, It's a reasonable statement to say the purpose of trauma therapy is to create more integration in your client's brain. Reintegration of three aspects of the brain that have become disengaged: the thinking mind, the emotion mind, and the body. Next, I'm going to also highlight three areas of the brain that are the most relevant to our discussion today: the amygdala, the hippocampus, and the prefrontal cortex. I'm sure you're familiar with this. The amygdala is the fear center of the brain. In the wake of trauma, it becomes hyperactive, stays on high alert, hypersensitive to danger, and it's reactive. Because the brain prioritizes survival, fear circuits are strengthened. This makes the fight, flight, or freeze response the default. People get stuck in this response. While the fear circuit is strengthened, links to rational thought and emotion regulation are weakened. Unprocessed trauma memories may become isolated from the rest of the brain's networks. All of these symptoms relate to the arousal and reactivity symptoms of PTSD: irritability, exaggerated startle response, hypervigilance, concentration difficulties, sleep disturbances, emotional dysregulation, as well as intrusions and recurrent, involuntary, and intrusive memories, visual images, and dreams that are disturbing and upsetting. I've worked with people who've come to the clinic having lived very restricted lives due to this enhanced fear response, who are living in a closet, afraid to open the door even to friends who shopped for them, or have not left their home in years due to these fears, who can't look you in the eye for fear of what they think you will see. We know that fear only increases avoidance, which creates a vicious cycle of avoidance and fear, fear and avoidance. The hippocampus, we know from research, becomes smaller over time after people experience trauma and to become underactive. This is due to elevated stress in the body and associated cortisol levels, which in turn impairs memory formation and the ability to contextualize traumatic events. This leads to fragmented memories. These changes make it difficult for the brain to distinguish between past traumatic memories and the present reality. During the traumatic event itself, cortisol that is released shuts off hippocampal function. At the same time, adrenaline is increased, and that increases amygdala function. So adrenaline increases the establishment of certain kinds of memories, traumatic, upsetting, stressful memories, but cortisol decreases the integration of these memories. All of this contributes to the PTSD symptoms of intrusive thoughts, flashbacks, poor memory, poor concentration. It also explains neurologically the reasons that traumatic memories are fragmented and unlike other types of memory. Very important. I've worked, and maybe you have, with people who initially can't really recall many details of traumatic events that they know they've experienced. And yet, they have terrifying dreams or flashbacks of these very experiences. People who doubt they can heal because they can't remember. I want to give you an example of someone who really typifies these neurological states. When she came to me, she was in her 30s. At her latest admission, she was in her late 30s, having returned after several years because she hadn't really gotten better. Her life hadn't changed much. We had tried both CPT and PE, but she couldn't complete the assignments or do the work due to her avoidance. She earnestly wanted to heal. but couldn't bring herself to do what was required for these treatments. Her only options at a certain point in our therapy, well, she had two options: leave without getting the help she wanted, or try Memi, which she had said was voodoo and rejected the first time we had that discussion. She had experienced multiple instances of sexual, physical, and emotional abuse from what she thought was age 3, as well as 2 sexual assaults as a young military recruit. She was unable to work or go to school. She hadn't left her apartment in over a year when I last saw her. She had one person she was able to relate to and really had only sporadically engaged in virtual therapy. She had a lot to process. If you would have seen her, you would have seen a woman who had very unusual physical tics and habits, expressed herself in odd verbal phrases, couldn't look you in the eye, wouldn't allow herself emotions, but sure could talk herself into or out of anything. She was very intelligent, but you wouldn't know it from being with her. But she knew me, and she trusted me to work with her, and so she did decide to try Memi. Very skeptically, I must say. We started with what was available to her, her 2 adult sexual traumas, and we worked on these in 2 Memi sessions. At that point, she was starting to believe she could be helped. And so we moved to events that she identified from her childhood. They were in varying degrees of what she described as fuzzy. She chose one event that was identifiable to her, and we started work on it. We had completed 2 sets. Her scores were moving. We got to the 3rd set, and in the middle of it, she asked to stop and said with a beautiful look on her face that she had identified a memory that she had long wanted to have clearly, and she called it her original sin. Being able to get clarity about this and other events from her childhood in and of itself was an immense gift to her. We went on to process 5 additional traumas from her childhood in 5 additional sessions. And at the end, I asked her for her thoughts about Memi. She had been so skeptical, so I was interested. And she said, "I don't know why anyone would choose anything else." Beautiful. Let's go back to the 3rd part of the brain that I want to talk about, the prefrontal cortex. As you may know, it's responsible for rational decision-making, emotional regulation, and whose communication with the amygdala becomes underactive and weakened after trauma. This results in difficulty managing emotions, impulses, as well as cognitive difficulties, problems with focus, decision-making, information processing, integrating information. These changes in the brain correlate to PTSD symptoms like trouble remembering events, having distorted thoughts of blame, having negative emotional and cognitive states, as well as increased episodes of recklessness and dissociation. Now I want to move on to talk about the ways in which Memi uses what we know about the brain and about trauma reactions and overcomes the limitations of cognitive and exposure-based therapies. And I'm including not only the steps of the protocol itself, but the fundamentals of the intervention and what we as providers bring to our sessions in ways to maximize healing. Focusing on the sensory and visceral elements of trauma rather than on the context, the details of who did what, when, etc., is a tremendous relief to most of the people that I've done Memi with, as is probably the case for you. This starts to create trust, which is foundational for any healing modality. In step 1 of the Memi protocol, we build on this by building connection, visceral connection, by breathing together, by our attending to their physical estate, by attuning ourselves with them. We achieve this less by talking and more by visceral tuning. This is a change that can be a challenge to implement for those of us who are used to talk therapies. We need to talk less and attend more to establish rapport. This is also the start of safety. We know that safety is critical for people with PTSD. I'd like to talk about this a bit because it's an essential precursor to healing. For traumatized people, we know that the amygdala is overactive. This is what it makes it difficult for them to manage their emotions, to stay present, to not overreact in situations that others see as non-events. Their heightened perception of threat is a barrier to full engagement. Until they feel safe, they're focused on protecting themselves, on shielding themselves from the next or a past affront. Most trauma therapies don't take this into account, or they may even infer a malingering intent with their avoidance. By focusing on trust and safety from the start, MEMI brings this front and center where it creates brain receptivity to the intervention. It's more receptive to what's about to come. We all know about the stages of change model, which lays out our levels of openness to people actually adopting or changing a targeted behavior. MEMI incorporates this explicitly in step 2, commitment to change. We don't guess and hope that they're willing to change. We actually ask them. And then we listen, as much with our ears as with the entirety of them, their voice, their body, the way they phrase their response. Again, we're using our visceral senses to gain an understanding of their openness to accepting any changes that may occur as a result of the therapy. And we know that the brain can only experience what it allows. We are asking them to imagine that it's possible for them to change and to assert their willingness to do so, really opening the door, so to speak. This step is empowering. It makes explicit the significance of their role in affecting change. And it's giving them control over what the problem state is. We know that power and control are generally lost as a result of trauma. By giving them the power to focus where they are able, and the control about the details of the event is a step in the opposite direction of powerlessness, helplessness, and lack of control. Building safety by empowering them and allowing them to control the context is a cornerstone for any healing from trauma and adversity. Research tells us that a relaxed brain learns better, absorbs more, and can more flexibly integrate knowledge. And these first steps were establishing and building trust and safety, which is enabling the amygdala to relax just a bit. This in turn opens up communication between the limbic system and the prefrontal cortex, which facilitates the integration of traumatic memories. The next 2 steps of MEMI further enhance safety, which in turn further positions the brain to be receptive to change. The way in which anchoring is done in MEMI, again, brings in viscerally a past experience that is the opposite of the emotion of the problem state. We help the individual fully re-experience that opposite emotion and strongly connect it to our anchor word. This is not just thinking about the opposite emotion, but revivifying it through all the senses and in their body. And we test the strength of the anchor by refiring it after a break. We are building on changing the limbic system as part of the treatment, not just as a result of the intervention. Imagine. Therapeutic dissociation brings in a way to help individuals separate their past from their present. We know this is related to the hippocampus. By calming the amygdala, less cortisol is being released, which is enabling the hippocampus to activate. This helps with integration of traumatic memories and to more clearly distinguish past from present. We are giving them a tool in this step 4, therapeutically, not reflexively to dissociate the past from the present. This also enables them to be more present, more mindful, both in the session and afterwards in their life. By enlisting mindfulness, we're helping them keep the prefrontal cortex online rather than being hijacked by the limbic system. From a brain perspective, our goal through these 4 steps is to calm the amygdala, to activate the hippocampus and frontal cortex, and to facilitate communication among these brain systems. This is also the goal of trauma therapy overall. We're enhancing the likelihood of that happening by establishing it during the session and using it to make those changes in the brain. Ingenious. Kudos to you, Dr. Denninger. Thanks for doing the work and sharing it with all of us. Step 5 can be the most activating for our clients, as it is the time that we're going into the sensory and visceral elements of the trauma. At this point, we use the techniques of the previous steps to help calm and ground the individual in the present. This, in and of itself, is a new pattern for people who are stuck in a fear cycle. We're helping them recall the traumatic event while lowering their reactivity and staying in the present moment. This is also a point at which therapists used to talking about or processing emotions in a session have to learn a new way to redirect people from the activating emotions back to the anchor and to therapeutic dissociation techniques. We're often tempted to want to process thoughts and emotions that arise. Those only serve to activate the limbic system. With MEMI, we're using the safety techniques to facilitate a new pattern of balanced limbic activity. Once we move into the eye movement sets, we're adding other elements that facilitate brain healing. The act of picturing an event on the wall at the same time that they're following our pen is a form of interfering with their normal reactions to that event. We know that I move in directions that reflect brain processing. If people are recalling visually, they tend to look up and to the left, right? Remember that? Their movements to other areas of the visual field by following our pen inhibits this response. It's a form of reciprocal inhibition. They're visualizing a traumatic event, but not leaving their gaze where it normally would be. In addition, by keeping them in the present moment at the same time that they're visualizing such an event, they're learning that it's possible to stay regulated at the time that they otherwise would be triggered. Very, very important. In my experience, the first set tends to relax people physically. This helps with amygdala deactivation, which in turn brings the hippocampus and prefrontal cortex online. Over the next sets, by using more of the visual field, we further interrupt previous brain patterns of the fear response. During the retest, we inquire as to any changes that have occurred, and we record these changes on our worksheet. By asking questions and eliciting responses, we're helping our client keep the brain integrated rather than dissociating or reacting in their previous patterns. This further moves them out of their trauma state of fear, paralysis, or overreaction. The final step in the MEMI protocol is also unique. First, we determine when we are complete based on the client's experience, not some predetermined number of sessions. We ask them if they're satisfied with the work they've done today. Again, this is empowering for people. Their input matters. Unlike other trauma treatments, we make this decision in collaboration, and they have the last word. I've seen many of my clients' involvement in this way and being in a calm state of mind, a calm limbic system, Say this is a new experience for them and a delightful surprise. We set the stage for a future in which this memory is triggered and they respond differently. This is all the first part of step 10, as you know, future rehearsal. This ability of theirs to envision a time when they become aware of the memory and not overcome by their reactions helps them understand that there is a choice in their recollection, which in turn gives them freedom, perhaps a freedom they've never experienced. These are indications to us that our work is facilitating the integration of the brain and of the person. Trauma therapy doesn't have to take so long or be so difficult. Thanks for listening.